Men's Health Day. So on this occasion, I'm going to talk on the erectile dysfunction in male. This is a common problem. Many people doesn't express the erection problem, and they'll be suffering. They'll be trying the lot of home remedies. In the end, they come to the doctor. So we'll look into what are the causes of this erectile dysfunction and what is the treatment. Now, this is a brief about the anatomical structure of the penis. You all know that the penis has got two corpora cavernosa, one corpora spongiosum, which accommodates the urethra, and the glans penis. So all these are important for good erection. Now, coming to the blood flow, the artery starts from the internal iliac artery, and then it from there epidendal artery comes. Epidendal artery divides into the three branches: bulbourethral artery, cavernosal, deep artery of the cavernosal, and then dorsal artery. So what happens during sexual excitement? Erectile tissue in the body of the penis fills with blood, and the penis enlarges, so becoming ridge and erect. So erection is what allows the penis to act as a penetrating organ for delivering semen to the female reproductive tract. So contraction of the muscles surrounding the root of the penis enables erection, the ejaculation to occur. So the types of erection, or one is psychogenic, other one is reflexogenic. So what is psychogenic? It is the response to either auditory, visual, olfactory, and imaginative stimuli generated in the brain without physical touch. So this is psychogenic. So you look at some beautiful picture, you get aroused. So this is called psychogenic. So it is mediated through the sympathetic thoracolumbar outflow, and the parasympathetic outflow also will be partly participating. Now, the reflexogenic erection, it occurs when there is a direct stimulus to the penis. The glans penis is the most the sensitive organ. So when it is stimulated, so there will be reflexes going through the spinal canal into the brain, and then the brain sends the impulses for the engorgement of the penis. So this is called reflexogenic erection. Now, you must have heard about nocturnal erections. They are involuntary. All males, healthy males, will get in early morning erections. So if the system is all right, that means that the hormone system is okay, and there is no organic cause, so they will get erections. So this is how we differentiate between if the patient says that he is not getting erections, so then talk to him, find out whether he gets early morning erections. If he is getting, that means that he may be lying to get some benefit out of that. Now, this is how when there is erection, when there is a stimulus, at the nerve root levels, the nitric oxide is released, and then it will relax the smooth muscles, and there is an enzyme called cyclic AMP. Through that, and there is a PDE5 enzymes which will regulate the erection. The PDE5 is an enzyme which breaks down the cyclic GMP, initiating the end of erection. So when the nitric oxide is released at the nerve endings, the cyclic GMP gets activated. So this stimulates the smooth muscle relaxation, and there is pooling of blood, and erection, patient gets it. So once the stimulus goes off, the PDE5 will come, and then will block the action of the cyclic GMP. So we'll come to know more about all these things when we discuss further. So remember, PDE5 inhibitors we use as a routine, so that the It won't go. It won't damage the cyclic GMP. Now, a brief about the prevalence and etiology of erectile dysfunction. It is very difficult to give find the etiology for all erectile dysfunctions. It is many times it is psychogenic. We'll look into that. And so the definition is inability to attain and or maintain penile erection sufficient for satisfactory sexual performance. This is called erectile dysfunction. So the definition varies from individual to individual. Now, there is one study which showed that the erection, sustained erection, is varies from the country to country. In India, it is about 5 minutes. In US, it is about 8 minutes, like that. In African countries, it is about 10 minutes. So it varies from countries to countries. Still, we don't know completely about this erection and erectile dysfunction. So there should be at least a 3 months history should be there, the symptoms, to make that diagnosis that this patient is having erectile dysfunction. Because even if he is lying, it is very difficult for us to prove. Now, what are the events which results in penile erection? One is there should be a sexual stimulation. There will be a decreased peripheral resistance. So then the blood pooling in the cavernous sinusoids occurs. And then there is an increase in the pressure of the intracavernous pressure. The muscles will relax. So engorgement and erection occurs. So this is the flow. Now, coming to the etiology, it can be organic, it can be psychogenic, or it can be a combination of these two. What are the organic causes? One is a vascular problem, like suppose a 60 or 70-year diabetic patient who comes to you with erectile dysfunction. So we may have to suspect that there may be vascular pathology. The cholesterol might have deposited. There will be an obstruction to the pudendal artery or the dorsal artery of the penis. So the blood flow is not sufficient. So this may be the thing. There may be neurogenic. There may be a spinal cord injury that can also produce, or there may be a deficiency with the hormones. The testosterone level will be very low, maybe low. Then there may be a penile injury, local problems, or a disease in the penis. And then some medications, antihypertensives, we look into that, what are the medications. So all these things can cause organic erectile dysfunction. Psychogenic causes, you know that it is a depression, performance anxiety may be there, the relationships may not be good, and then there may be psychosocial problems. So there is a psychological distress. So many things will add into the psychogenic erectile dysfunction. Now, coming to the incidence, it is reported depending on the age group. It is more common in the older age, after the age of 60 years, and below 60 years, it's about 16 to 25%. So as age advances, the ED also increases. Now, what are the major risk factors for erectile dysfunction? One is aging, because aging, the blood flow to the various organs come down because of the blocking, atheromatous plaques blocking. And then there may be a lot of psychological issues. There will be a lot of stress in the family. The familial problems may be there. And then there may be low hormones in the body. There may be chronic diseases like hypertension, diabetes, cardiovascular diseases, and unhealthy lifestyle. The excessive alcohol consumption is like Shakespeare says, it provokes the provokers, but taketh away the performance. So the alcohol will produce liver damage, and then the testosterone production will be less. Smoking again, the hormones will come down, the blood flow to the testes will come down. So these are the various medications: antihypertensives, thiazides, beta blockers, antidepressants. So all these drugs may be a risk factor for erectile dysfunction. So when you're dealing with a patient of erectile dysfunction, we should take this history very clearly. Again, same thing. We'll go into the next thing. Now, so these are the various treatable disorders which will be associated with erectile dysfunction. That is lipidemia in 60% of the men. They may be obese, and then some cardiovascular problems, hypertension, coronary artery occlusions, which are associated disorders. They may be having diabetes, may be having depression in these erectile dysfunction people. Now, it has been observed that the blood vessel which supplies the penis and the coronary arteries are of the same caliber. So, in case there is a cardiovascular problem, or in case the patient has got erectile dysfunction, he may be having a cardiovascular insufficiency also, ischemic heart disease. So, this is the correlation which has been seen. Now, why diagnosing ED is important? Because it results in anxiety, it decreases self-esteem, it reduces the quality of life, and there will be a negative effect on the relationships. And also, the regular sexual contact is a type of exercise to the body. So a person who is active sexually is more healthier because he does some exercise. Physical activity is there. So that's also very important. Now, coming to the diagnosis of erectile dysfunction, which we already discussed, we have to take a good history. Examination has to be done. Whether there's any problem in the locally, the penile problems are there. Sometimes Peyronie's disease will be there. There will be thickening of the subcutaneous tissue over the penis. So that may be producing pain, or there may not be erections. So, and then some laboratory investigations like testosterone, lipids, blood sugars should be checked. And then occasionally we look into the prostate specific antigen, especially in the older age, beyond 60 years if they come. So we can detect any prostate cancer being the cause, because in case we are treating erectile dysfunction with the male hormone testosterone, we should look into the PSA values. If the PSA is on the higher side, we're not supposed to give unless we prove that this patient doesn't have, say, a prostate. So this is the comprehensive history we have to take: erectile insufficiency, any partner's altered patient or partner sexual desire, whether he gets ejaculation or not, whether he gets orgasm or not, any pain, and the medical history of comorbid conditions, any psychological disorders we should take in the history. So in conclusion about the etiology, it is caused by a combination of organic and psychogenic factors. It is highly prevalent with the increasing age, and many people do not advise to come to us to take a treatment, because they think that after the age of 60 or 65, it's not very essential to have a sexual contacts regularly. But to be honest, it is nice to be sexually active even after the age of 60 or 70, so that it is a type of physical activity and keep the person happier, and it also keeps the other partner happy. Now we'll come to the management. Now, before 1970, we always think that it is a psychological, so it is treated, but it used to be treated by the psychiatrist. Then, from 1970 to 1998, the penile implant was the gold standard of a treatment. Then came the vacuum pump, where you put the pump and create a vacuum so that a lot of blood sucked into the penile body, corpora cavernosa, becomes erect. then put a ring to the root of the penis, and there will be some tumescence. But we have tried this out, but none of our patients were happy. The tumescence won't be very good in these patients, so we don't use that frequently. Then in 1980, the intraurethral drugs came. That is, prostaglandins tablets are put in intraurethral, and the patient gets erection because it relaxes the smooth muscles. And then intracavernosal injections, commonly used is papaverine, also is very effective, but it is painful to take injections, and repeated injection can produce fibrosis of the corpora cavernosa and problems later on. Now, after 1998, we got this the PDE5 inhibitors. Uh, so, when it comes to the management, these are the guidelines. One is, if the patient has got erectile dysfunction, you do the lifestyle modification, that is, stop smoking, avoid alcohol or less restrict the alcohol, good health diet, exercise regularly in the beginning before you start medication. So try this out in the beginning. If it doesn't work, and if he is hefty, lose weight, it will also help. Then if antihypertensives, beta blockers and all can be changed, or go to the other antihypertensive drugs. Antidepressants, if it is there. Anti-androgens, if he is taking, then he has to alter that, change it. And then there should occasionally we will be doing a counseling, because some people say that every day they like to have a sexual contact. As the age advances, it may not be possible. If he is keeping a good health, it is possible. Otherwise, it may not be possible on his own. So with the drugs, it may be possible to have a sexual contact. So that should be explained to the patient. So these are the oral medications which we use nowadays: tadalafil, vardenafil, sildenafil. These are all the PDE5 inhibitors, wherein it blocks the cyclic GMP, and the muscle relaxation is prolonged. We look into that, how which drug works how long. So it inhibits breakdown of cyclic GMP, which is produced by nitric oxide. And when the cyclic GMP is pooled there, it keeps on relaxing the muscle relaxation. Okay, you look into the off-life of these drugs. Sildenafil and vardenafil off-lives are 3.7 to 3.3 hours, whereas the off-life of tadalafil is 17.5 hours. So there is up to 36 hours. Some people have found there is a good result. So in that way, tadalafil is a very good drug for long acting. And we also noticed that it is a better drug than sildenafil. The incidence of headache is less with tadalafil comparing to sildenafil. Tadalafil, it definitely improves the sexual satisfaction, and then uh, the overall sexual experience will be good. Overall satisfaction in majority of the patients, almost 80 to 90% of the people, we can use it. Usually we start with the 10 milligrams of tadalafil 1 hour before the sexual contact the patient has to take. Ideally, if he takes it before food is better. And in case he's not happy with 10 milligrams, we can try out 20 milligrams. So let him not try not more than 20 milligrams at a time. It is a well tolerated drug, especially in diabetics and antihypertensive patients. can be used. And the most common side effect is headache, dyspepsia, and back pain. Uh, you should you should be cautious. Those who are using alpha blockers, antihypertensives, alpha blockers, if they are using, it can produce postural hypertension. And then the so in addition to these alpha blockers, the other the therapies which we have advised, like losing weight, good exercise, good control of diabetes, stop smoking. 100% they should stop smoking, and then restrict the alcohol. So all these are also very important. In addition to that, the only caution is the patient who are ischemic heart disease, who are taking the trinitrates they for their heart. So you should be careful, because the addition of this also produces hypertension. Partial hypertension is a common problem. Now, what are the other therapies for the erectile dysfunction? Oral testosterone, transdermal, subcutaneous, or intramuscular testosterones can be tried. It's usually done if there is a deficiency, but occasionally we do it empirically also. Those patients who are not happy with the tadalafil, we combine the oral testosterone. And then apomorphine also can be used. It can be used subcutaneous injection or sublingual can be tried. Prostaglandins, this is called alprostadil. The intracavernosal injection can be tried, or transurethral therapy also is available. I told you vacuum constriction devices, they're not very effective. And then the surgical treatment, penile prosthesis is very good. We do these surgeries, but not very commonly. And the processes are two types: inflatable and non-inflatable. The Indian guy, one neurologist, has devised a processes which is much cheaper, and it is very effective. So we usually use that, whereas the inflatable processes is very expensive. So we rarely use that. In case there is a block to the blood vessels, then occasionally the vascular surgery corrections can be done, but the results are not very satisfactory. The various alternative therapies have been tried, like yohimbine, sorry, tablets, ginseng. So all this being tried, but not to the satisfaction. Testosterone, it should not be used if the patient has got a prostate cancer, and it should not be used in breast cancer, of course, in females. So it can be tried if the patient is not happy with the other medications, the PDE5 inhibitors. We can give 40 milligrams testosterone. Oral testosterone is undecoate is available. He will be taking every day. You try it out for 3 months and see whether he's going to be happy or not. But before you start testosterone, you check the hormone levels, you check the FSH, LH levels. If they are on the normal side, as an empirical treatment, you can try out for 3 months maximum. If it's not effective, then you go for the penile processes. And then the other transdermal preparations also are available. And then one injectable depots once in 3 months, patient can take it. And monitor the liver function tests, because all this testosterone can produce hepatic dysfunction. So look into that. Occasionally, you check once in a week or once in 15 days the liver function test. Intraurethral, it's already discussed. They can be tried. The hypertension is a problem, and then they can get the priapism, it is called. That is unwanted, sustained, prolonged erection. So that is called priapism. So you should be careful. If the erection is not coming down within 30 minutes, then patient should contact us. Otherwise, there will be ischemia of the corpora cavernosa, and the sinusoids will become fibrosed later on. So the erection is get lost. So it should be explained whenever we are giving the intracavernosal injections or intraurethral routes of alprostadil and papaverine. Is what the papaverine, which is much cheaper, it's available easily in India, and we inject into the corpora cavernosa, diluting 30 milligrams of papaverine with another 5 ml of normal saline. Inject it, and within 3 minutes, the patient will get an erection. So this is one way of checking whether the blood flow to the testis is okay or not. Is a smooth muscle relaxant. As mentioned, vacuum erection devices are not very satisfactory, so we don't recommend as a routine. So, in summary, the treatment of erectile dysfunction, the initial treatment is already mentioned exercises, the restricting the alcohol, we have to stop the smoking, and then lose weight, then look into the drug history, what drugs he is taking. If all these things are okay, then PDE5 inhibitors is the first choice. If it doesn't work, we straight away go for the penile implants rather than of doing all these injectables, which the patient won't be happy. The the cavernosal injections of papaverine or alprostadil, the patients are not very happy. So we go for penile implants. So these are the few, the guidelines by the American Neurology Association, erectile dysfunction. Uh, I'm not going into the various details of that. Whatever we have discussed is there in this. Thank you very much. That's all I can say about the erectile dysfunction. And any questions, I will be very happy to answer. There is one question from Joseph Matthew. Patients are on nitrates. What precautions should we take by prescribing tadalafil? I think my suggestion is totally avoid, because they will have hypertension and problems. So the cardiac function is more important than the erection. If it is really bothering him, then I suggest him to go for a penile implant. It is done under local anesthesia. It is simple to insert, and just 10 to 12 hours admission is sufficient. And it is better when the patient has got a ischemic heart disease, to promote have sexual contacts, because any physical activity, it may be more deleterious to the patient, dangerous. So look into all those things. How is his ejection fraction? It is also important. If his ejection fraction is good, if it is bothering him, the sexual dysfunction, then my suggestion is, rather than trying these medications, uh, my suggestion is go for a penile implant. Instead of tadalafil, you can try that apomorphine orally, which may be little effective because it is centrally acting. So, okay, thank you, Matthew. The other question is from Goyal Arnav. What what is your drug of choice in tadalafil? Yes, we already discussed tadalafil or sildenafil. My drug of choice is tadalafil. We have used sildenafil earlier, 50 milligrams, even up to 100 milligrams. A lot of severe headache these patients complain after taking the drug. So I stopped prescribing it. Tadalafil is very good. So please try, start with 10 milligrams of tadalafil 1 hour before the sexual contact, and empty stomach before food is better. If he's not happy, he can increase it to 20 milligrams, uh, not more than 20 milligrams. Uh, so that's my suggestion. Goel.
Hello. Hello.
Yeah,
So just wait for 1 to 2 minutes. If delegates have more questions, then they will ask.
yeah. Shall we end it?
So just wait for 1 to 2 minutes. Sir.
Sure, sure. Thank you. Fortunately, the drugs, tadalafil or sildenafil, is become more affordable in India comparing to the other. When they released Viagra, which was very expensive. So thanks to the pharma people in India who made it more affordable. So we are more freely using these drugs. And many patients also knows these trade names. So they're taking on their own. Yeah, I have one more question from Abhay Naik, who are BPH with ED, but they are facing problems of retrograde ejaculation. Yes, see, retrograde ejaculation occurs only after the surgery. It is a known thing. Unfortunate that once we do a prostate surgery, retrograde ejaculation is a must if we are relieving the obstruction. So that we always explain to the patient. And one second thing is patient is not psychologically is disturbed because of the retrograde ejaculation. So explain to the patient beforehand, unless you are planning to have a child, retrograde ejaculation is not going to bother you in any way. You are going to get a sexual satisfaction. It's not an issue. Semen comes out, but it doesn't come front because the bladder neck is wide open. So as soon as the semen comes out, it goes back into the urinary bladder. So when he passes urine, it will come out in the urine. There are no side effects with this. But patient is seen semen coming out since several years. Now it is not coming out. This is the problem. But there won't be any erectile dysfunction by doing a prostate surgery. So, in case he is getting a erectile dysfunction, it is mainly because of the age and because of the psychological worry that he has undergone a surgery. A common man, any minor surgery means he keeps remembering that I've undergone this surgery, I've undergone this surgery. For everything, he correlates with that. So we have to give some psychological advice to the patient. And then, yes, if he has got erectile dysfunction, try tadalafil. But retrograde ejaculation is not an issue. It should be explained to the patient. Yeah, I've got one more question from Matthew. Erectile dysfunction plus PE. Do you use addition of depoxetine? Oh, yeah. Yes, yes, yes. Sorry, you're right, Matthew. I forgot to mention about uh, um, the premature ejaculation. Yes, it is a big issue, especially the younger age group. It's a big issue. So we occasionally we do combine depoxetine. The unfortunate problem with depoxetine is they get a lot of drowsiness. So we do combine, but we usually counsel the patient. The simple way of counseling my patient is that in a kitchen, lady who does regular cooking, when the water is boiling or milk is boiling, they remove the lid without using a towel or have some fold handle something. They within seconds they remove the lid. But if you go inside, you cannot remove it. You will burn your fingers. How? It is by experience. So, like that, in the beginning stages, as soon as they see a image, they imagine some beautiful picture, the ejaculation occurs. Then the erection comes down. So, tell them that in the initial stages, this happens. And then you try with the tadalafil first. Without, don't give depoxetine. Tadalafil first. If he's not happy, then you add a depoxetine. Uh, but many times Younger age groups, it settles down on its own. Once they get used to the sexual contact, the over excitement comes down. If it is available every day to him, the over excitement will come down. If it's once in a while, he goes after 3 months, 6 months, like that, he goes and meets a partner. Naturally, there's so much of emotion, the ejaculation occurs first. Yeah, yes, Goel, I have one more question. To improve sexual desire, do you prefer any Ayurvedic like? That's what not only in India, all over the world, there are so many things which has been tried. You know that I was reading that whale testis, shark testis, if you eat, you'll have a good potency. Even horse testis, if you eat, a good potency and all. Maybe all these things contains more testosterone hormones. So that may be the reason. I'm not tried Shilajit and all. Maybe there is nothing wrong. It's not harmful. Can be tried. More than everything, a good exercise and keeping the good physique will definitely gives a better sexual drive than all these drugs. There are now drugs available, a combination of depoxetine and the tadalafil. Um, some combinations are there. One drug which I can remember is Uphold. It is very good. Many patients are happy, especially a lot of the older people. They're very happy with the drug. So I think many companies should come out with these combinations.
So, sir, we have no more questions. So,
Yeah.
should we wait for 1 minute more or
Yeah, no
should we
issues.
conclude the
No
session?
issues.
Okay, sir.
It is a serious issue in the general public, but they are shy of coming out with the questions, meeting doctors. That's why they go to a lot of the um, I can say that non-medical people, quacks, you say. So take and spending a lot of money, taking a lot of drugs, and then penile massages, all these things being done. So we should thank you for this topic so that more people come to know at least some basic things or the causes of ED and the treatment aspect. Maybe it should percolate towards the family physicians, because they are the one who are going to treat, because they get the patients who are more confident with the family physicians because they are close to their surroundings rather than of the specialists.
So, sir, we have no more questions. So, with your permission, shall we conclude the session, sir?
Yeah, thank you.
Thank you, sir. On behalf of organizer, I would like to thank you for your insightful and educated talk. Sir, with this, I am ending the session. Thank you.
Thank you very much.